Good morning, all. Thank you for that introduction. At the outset, let me thank Pradeep sir and Dr. Ajit and the entire JIX team for inviting me for this lecture. And it's good to see so many people on Sunday morning, and much better than many national conferences. I was thinking, why did they give this talk to me, the palliative care? So I practice intensive care. And I had to talk about the palliative care, again the palliative care at home. So if you see, all the fields are getting subspecialized, all the disciplines, like intensive care is also, it's vast. You need to subspecialize at some point of time. See, some of us do neurocritical care, some of us do cardiac critical care, some of us do surgical critical care. And how many of you have seen patients at home? Yes, many of us have seen patients at home. And how many of us try to practice palliative care? Many of us. So we must know what is palliative care and what is palliative care at home, how to provide. So the palliative care aims at providing the quality of life of a patient who is suffering from chronic ailment. It's not about the cancer. So we think when you talk palliative care, so you think about cancer patients, oncology patients. It's not about oncology patients. Palliative care we provide for the patients with chronic diseases, advanced cancer, lung, renal problems, cardiac problems, a patient with congestive heart failure, and like cardiomyopathy, severe cardiomyopathy, or a patient with Parkinson's, later stages of Parkinson's disease, or a patient with dementia, they require palliative care. And all these, like palliative care is nothing but long-term care. It's a bridge between the intensive care and our hospice. We'll see what is hospice. So around 1.5 billion people in the world experience chronic pain, and more than 61 million people require palliative care. So we know death is inevitable, but in today's era, we look at the quality of life and then how we provide the quality of life. So we know hospice and palliative care, they overlap, but so if you go back to the history, like someone told just before, the hospice, it's hospice, it's like a guest and guest rooms, or they started like a guest room for the travelers, and then later they changed the hospice to provide care for the terminally ill patients. And later, after 1970s, the palliative care became popular, and then all the major hospitals, they provide palliative care, and then now we try to provide the palliative care in the community and in the home care setting also. So if you look at the principles of palliative care, the principles of palliative care affirms the life and regard the dying as a normal process, and determine the patient's values and preferences, and establish a good care plan, and involve the family members, and try to mitigate the discomfort for the people, whether they are in the hospital or whether they are at home. So if you look at the WHO definition of palliative care, if you look at palliative care, end-of-life care, and then the hospice care, it overlaps, but there are clear differences between amongst all these three terms. So the WHO definition of palliative care is an approach that improves the quality of life of patients and their families experiencing problems related to life-threatening diseases. So it is provided through prevention and treatment of plan and other physical and psychosocial, and you have to address their spiritual problems. So considering the increasing the cost of treatment of chronic illness, it is not possible to keep a chronically ill patient in hospital and pay lakhs of rupees to the hospitals. So you need to take these patients home, and then we need to provide a cost-effective palliative care for these patients at home. And the family members are very smart. They take care of patients. So recently, I think 1 year back, I have come across with one MND patient, amyotrophic lateral sclerosis patient. Daughter is excellent. She takes care of father. The father is on tracheostomy, on BiPAP. And these family members, they're very smart. If you train them, they take care of these patients. And then you keep getting the photos. So we celebrated second birthday on ventilator. We celebrated third birthday on ventilator. So, and you have to be very, very careful when you are dealing with these patients. And if you are bad, if you neglect them, and then if you are bad, you will never get any MND patient to you. And then if you are good, then I started getting lot of patients from one reference. Then I came to know these people, they have a WhatsApp group across, and in that WhatsApp group, they have MND patients across the country. And then they discuss with each other what type of tracheostomy tube we are using, what is the most comfortable tracheostomy tube, and when you are changing. So those things they discuss, and then you don't believe, they have a newsletter. Every month they release a newsletter. In that newsletter, they mention who is the best neurophysician for MND patient, who is the best palliative care doctor for MND patients. So like that, they have groups for MND patients, they have groups for Parkinson's patients. They discuss amongst them. So we need to, we have to be empathetic, and then we have to be straightforward with them. So when you are providing home-based treatment, so you have to be very, very careful, and then you have to provide proper care. The palliative care at home, when the palliative care is provided at the patient's home, it provides a sense of safety for them, and then it gives a lot of privacy, confidentiality, and it is a specialist home-based palliative care. It improves the symptom control and health-related communication and psychosocial support, and then you need a team to provide palliative care. So you need specialized nurses, you need specialized medico-social workers, and then you need physiotherapists, and then you need even massage therapists. You need a lot of people to take care of these people, these patients, and then to mitigate the discomfort for these patients. So if the patient is at end of life care or the terminally ill, so the importance of home palliative care is controlling the distressing symptoms of illness like pain, pain relief, and home-based palliative care gives independence, intends neither to. It is not to hasten the dying process or to postpone the death. It is to provide the comfort, and then helps in planning the future and preparing oneself for the inevitable death, and affirms life, regards dying as a normal process. So you have to provide the empathetic care at during the end of life. This will enhance the quality of life, may also positively influence the course of illness. So for a caregiver, you need to support the caregiver also. The family members play important role in caring of chronically, critically ill, debilitated patient. The informal care by family members is unique in developing countries, and the family members are at ease. If you train them, they provide excellent care to their own family members. So if you look at and then you have to take care, you have to train them about the skills in the primary palliative care, like you have to identify and treat cancer-related or chronically non-cancer related treatment related symptoms. You have to take care of pain, nausea, you have to take care of constipation, urinary frequency, urgency, hematuria. If they develop malignant bowel obstruction, you have to take care. You have to take care of ascites, anorexia, and then nutrition. And a lot of people during the palliative care, they will stop eating, and then whatever you do, they will not eat. And then if you try to feed them through a nasogastric tube, they will pull it out. So they don't want to continue. So these things we need to address. And respiratory symptoms, the breathlessness, cough, and then we have some emergencies in the palliative care. If they have sudden GI hemorrhage, if they have seizures, and malignant spinal cord compression, superior vena cava obstruction, hypercalcemia, delirium, all these are palliative emergencies. And then as a palliative care physician, you have to be good in dealing with these palliative care emergencies. And then nursing issues, care of bedbound patient. We need to train the nurses about care of these patients. And then we need to provide the wound care, enteral feeding, lymphedema. Somebody should be expert in managing lymphedema to take care of these patients at home. And then we need to provide psychological and psychiatric support to identify and treat uncomplicated depression, and then identify the deficient housing, transportation, food insecurity. They will have lot of social problems. We need to address them, and then conduct a spiritual screening and assessment for the distress, and beware of the community resources that can help to address spiritual distress in these patients. So discuss the dying with the patients and caregivers. Understand hospice. Hospice, as I told, it is different from palliative care. You provide hospice during last 6 months of their, like during end of life care. And if you think the life is limited, end of life, and then mainly oncology patients, they go to hospice for a better care. So to set up home palliative care, you need a central meeting point, storage facilities, transport team, and method of communication, either telephone or mobile. We use tele-ICU command center sometimes to monitor these palliative care patients. You need doctors, nurses, volunteers, huge manpower is required, and medications, equipment, you need to documentation, and then the finances. You need to provide salaries for all the team members. Again, you are providing cost-effective palliative care, but at the same time, you need that you have to keep in mind, and then you have to take care of the finances. So this is the home care kit, like many home care like service providers. They provide palliative care at home, and then they should have a home care kit of stethoscope, BP operators, thermometer, tongue depressor, all the basic equipment they should have, and then they should have tools for the dressing and for the wound care. And then they need to keep some medications to control the symptoms, like painkillers they have to keep, and then they have to keep antiemetics, they have to keep some basic antibiotics, and then they have to keep sedative agents. And the major challenge is training. I know you might have seen a lot of home care people, a lot of home care companies in this country, they come and tell you, we provide palliative care. So with whom they are providing palliative care? Do they have nurses who are trained in palliative care? Do they have doctors who are trained in palliative care? So if you go to any home care company, they say, yeah, we give them a module, we train them for 1 week, and then these people will take care of the palliative care. But for doctors, we have fellowships for 6 months, 1 year. For the nurses, also we have certificate courses for more than 4 months. And then these people, the right people, should provide palliative care so that we'll get, the patients will get holistic care. And we need to monitor these patients. We know telemedicine. We have critical care command centers in most of the hospitals. We monitor critically ill patients. And the home care companies, they have their own command centers. And so when you are taking care of a palliative care patient, and when you're monitoring these patients, you don't require hi-fi critical care command center with Philips Psycho software, and because we don't require that much. You won't get so many values, and then so many inputs from the spike center, and then it is more expensive. So we have very, very cheap, inexpensive remote monitoring devices, and then we can use these things, and then we can monitor the palliative care patients. And the problems are, like most of the places, we don't have proper internet, and then the connectivity will be a problem when you're monitoring these patients from home. So as already discussed, the pain is crucial in managing relieving the pain is the integral part of total care concept of the palliative care. So we can use different pain scales, and then we can use different methods to control the pain. And then if it is mechanical allodynia, we can use cotton wool, or we can use artist brush. With this we can control the symptoms. And then you need to identify why these patients are having pain. Sometimes you need to do MRI to see is there any bone metastasis, or sometimes you may need to do advanced scanning to find out. And then we know this WHO ladder. So we first give NSAIDs, weak opioids, strong opioids to control pain in the palliative care. So if you look at the strengths of palliative care at home, it gives personal touch in care delivery and time dedicated for counseling. You dedicate a lot of time when the patient is at home. And the balance of medical and nursing, psychiatric counseling, we provide comprehensive patient history documentation and contextual immediate solutions you will get, and the relations that are built when you are providing home palliative care. At the same time, it is not as efficient as hospital-based palliative care. The efficiency is low. So each visit, you must have a clear agenda, approach to medication, medication management with the home care team is also not that efficient. So we don't get good trained nurses to provide palliative care at home. And then again, the feedback mechanism, we should get good feedback from the home setup, from the home health care to provide good palliative care. So with this, I'll end my talk. This is our ISCCM Hyderabad flagship conference, which we are doing in November, Critic 2022. And we have various workshops, and then we have conference on 5th and 6th November. So all of you welcome to the Hyderabad Critic conference. Thank you so much. This is one of our patients with Parkinson's, and then they were asking us who is the best palliative care doctor, but they couldn't find best palliative care specialist. They were following a neurophysician. Neurophysician was treating this patient at home, and this patient had a fall at home, and then after that, this patient came to the rehab, and then he was admitted in the rehab. So this patient family, they bought this hoister because the wife could not lift the patient and put the patient in the wheelchair. So the wife bought one hoister and then this to lift the patient and put the patient in the wheelchair, and the wife was taking care of the patient, this patient at home. So with this, I will end my talk. Thank you. Thank you so much.
Thank you, sir. In critical care, so far, we have given importance to quality of health. Only now, I think we are beginning to understand the importance of quality of death, especially giving a good death. Palliative care at home goes a long way in achieving this. Thank you for the wonderful talk, sir, and thank you for keeping to the time. Thank you.